Welcome back to the PEM Fellowship EKG curriculum. Our topic today is long QT syndrome and Brugada. Remember that you can always refer back to the basics module if you have any questions, and that you should pause this module if you need more time to review the EKGs shown. First, let's start with a case. You are seeing a patient in the emergency room. A 12-year-old girl presents with a syncopal episode and loss of consciousness for 2 minutes. She is back at baseline now. She doesn't recall any preceding symptoms, including dizziness, lightheadedness, chest pain, or shortness of breath. Her family was with her and did not see her have a seizure. Her vital signs show a blood pressure of 104/65, heart rate of 95, oxygen saturation of 100% on room air, and a respiratory rate of 14. Her physical exam, including orthostatics, is normal. You decide to get an EKG. This is what you see on her EKG. Let's use the method we learned in our basics module to go through this EKG together. Calculate the rate, rhythm, and access. You should have found that the rate is just over 100, closer to 110. The rhythm is sinus because you can see a P before every QRS and a QRS for every P. Given that the QRS is up in both 1 and AVF, you can determine that this EKG has a normal axis. Next, let's calculate our PR and our QTC intervals. You can see that the PR interval is about 140 if you multiply 3.5 small boxes by 0.04 seconds each. To calculate the QTC, you should have used a QT interval of 0.36 and an RR interval of 0.56. Using the formulas shown, you should get a QTC of 481. For a 12-year-old girl, this is prolonged. Before we skip ahead, take a minute to look at the morphology. In this EKG, the morphology of the P waves, QRS complexes, ST segments, and T waves are normal. Therefore, our only abnormality on this EKG is the prolonged QTC. Long QT syndrome is defined as having a prolonged QT interval. The precise number is age and sex dependent, but in general, postpubertal girls should have a QTC less than 460 milliseconds, and postpubertal boys should have a QTC less than 450 milliseconds. A good rule to remember is that anyone with a QTC longer than 470 milliseconds should be seen by cardiology urgently in the ED, regardless of presenting symptoms. Long QT syndrome may be congenital or acquired. There are at least 12 different ion channel mutations that cause congenital long QT syndrome. Two types of long QT syndrome type 1 include Romano-Ward and Jervellen-Lang-Nielsen syndrome, which you might be familiar with. There are also acquired long QT syndromes due to electrolyte abnormalities or QT prolonging medications. In terms of congenital long QT syndrome, the majority of cases are made up of 3 main forms of the disease. Long QT type 1 makes up 40 to 55% of cases and is associated with exercise, especially swimming. Long QT type 2 makes up 35 to 45% of cases and is associated with emotional stress or surprise. Long QT type 3 makes up 8 to 10% of cases and is associated with arrhythmia during sleep. It may also be associated with Brugada syndrome, which we will discuss later in this module. Acquired long QT syndrome can be due to a variety of causes, some of which include hypokalemia, hypocalcemia or hypomagnesemia, anorexia, amiodarone, macrolide antibiotics, voriconazole and posaconazole, TCAs, haloperidol and risperidone, SSRIs, methadone, ondansetron, and cocaine. The problem with having a prolonged QT, and the reason it can cause so many problems, is that it leads to prolongation of the action potential by increasing the time required for repolarization. This then allows time for oscillations in the membrane potential, which may lead to polymorphic VT or torsade. Remember that long QT syndrome can present as palpitations, syncope or presyncope, seizures, or sudden cardiac death. The risk of sudden cardiac death varies with sex and age, as well as with the specific mutation causing the prolonged QT. The length of the corrected QT interval is a significant predictor of cardiac events, where the longer the QTC, the higher the risk of sudden cardiac death. Remember that anyone with a corrected QT of longer than 470 milliseconds should be seen by cardiology urgently in the ED, regardless of presenting symptoms. You should also be thinking about long QT syndrome when there is a story of emotional stress or physical exertion preceding syncope or seizure activity. Let's go back to our case. You still have a 12-year-old girl with a syncopal episode who is back at baseline, except now you have the EKG shown. Calculate the rate, rhythm, and access. You You should have found that the rate varies between 65 and 95 because of the sinus arrhythmia on this EKG. The rhythm is still sinus because you can see a P before every QRS and a QRS for every P. Given that the QRS is up in both 1 and AVF, you can determine that this EKG has a normal axis. Next, let's calculate our PR and our QTC intervals. You can see that the PR interval is 120 if you multiply 3 small boxes by 0.04 seconds each. Because of the sinus arrhythmia, the QTC is a little trickier to calculate. Typically, you should calculate 3 to 5 different QTC intervals and average them together. Here we used these intervals and got QTs of 405, 450, and 417. We averaged these together to get an overall QTC of 424. The numbers you calculated may be slightly different from ours, but should be similar. In this case, you can see that the average QTC is not prolonged. Now take a minute to look at the morphology on this EKG. In this EKG, the morphology of the P waves, QRS complexes, ST segments, and T waves are normal. Patients suspected of having long QT syndrome and their family members often need to undergo further cardiac and genetic testing. Therefore, all of these patients should be referred to cardiology. If a patient is symptomatic from their prolonged QT, cardiology should be consulted while they're in the ED. Otherwise, this cardiology evaluation can be done as an outpatient. Management typically involves beta blockers with or without pacemaker and ICD placement. Other antiarrhythmics, including mixilotine and flecainide, can be used as well, but these are typically not first-line therapies. Patients should also avoid QT prolonging medications, as well as medications that lower their potassium or magnesium levels. They should also be advised to avoid competitive sports or strenuous activity. Now let's go back to our case one more time. Your 12-year-old girl with the syncopal episode is back at baseline, but this time you get the EKG shown. One last time, calculate the rate, rhythm, and axis. You should have found that the rate is about 80. The rhythm is sinus because you can see a P before every QRS and a QRS for every P. Given that the QRS is up in both 1 and AVF, you can determine that this EKG has a normal axis. Next, let's calculate our PR and our QTC intervals. You can see that the PR interval is about 140, since it is about 3.5 small boxes. There is no arrhythmia on this EKG, so we calculated the QTC to be about 401. Now take a minute to look at the morphology. Do you notice anything abnormal? In this EKG, you should have noted the abnormal QRS complexes in V1, V2, and V3. What you see best in V1 and V2 is a pseudo right bundle branch block and a persistent ST segment elevation. This is consistent with Brugada pattern. There are 3 types of Brugada patterns seen on EKGs. Compare each to the normal V1 to V3 shown here. The Brugada pattern seen on the previous EKG is type 1. As we said, Brugada type 1 is described as a pseudo right bundle branch block and persistent ST segment elevation in V1 to V3. This is referred to as the Cove pattern. Compare this to Brugada type 2 or 3, which is more of a saddle-shaped pattern with a positive or biphasic T wave, and is also seen in leads V1 to V3. In the example shown, it is best seen in V2. The difference between Brugada types 2 and 3 is the amount of ST elevation. Brugada type 2 has greater than 1 millimeter of ST elevation, while Brugada type 3 has less than 1 millimeter of ST elevation. Any of these cases of Brugada pattern should be followed up by cardiology. If the patient presented with or has a concerning history, cardiology should see the patient in the ED. Otherwise, this can be done as an outpatient. Remember that patients with Brugada syndrome may have any of the shown EKG findings at various times, depending on the precise clinical situation. Here you can see an actual EKG with the Brugada type 2 pattern. Note the saddle-shaped deformity in V2 with approximately 1 millimeter of ST elevation. Brugada syndrome is rare, but is seen in children and adults. It leads to sudden cardiac death by causing ventricular arrhythmias. One of the genetic abnormalities that leads to Brugada syndrome is the same ion channel mutation that causes long QT syndrome type 3. Therefore, these disorders may be seen in the same patient or in the same family. Patients with Brugada pattern on their EKG should undergo provocation testing by cardiology to see if they truly have Brugada syndrome or simply the EKG pattern, which is benign. Brugada syndrome is defined as having the EKG abnormalities and having either a personal or family history of spontaneous or inducible ventricular arrhythmia or sudden cardiac death. There are finer details to this distinction, but we'll leave that to the cardiologist. In terms of treatment, these patients with Brugada syndrome need an ICD. There is data suggesting that quinidine may be helpful, but this does not take the place of an implanted defibrillator. Beta blockers are not helpful in this disorder. We have now gone through long QT and Brugada syndromes. We often think of these together not only because they can be caused by the same mutation, but also because they tend to present in similar ways: syncope, presyncope, exercise or stress-induced events, drowning or near drowning, and sudden cardiac events in what appears to be a structurally normal heart. Remember that if patients are symptomatic from their prolonged QT or Brugada syndrome, or have gross abnormalities on EKG, this requires an urgent cardiology consult in the ED. On the other hand, if the patient is asymptomatic and there are only minor abnormalities on the EKG, these patients can be seen by cardiology in follow-up within a few weeks of their emergency department visit. We hope that you are now more comfortable recognizing and diagnosing these disorders and are familiar with the basics of their management. As always, we welcome your feedback and suggestions. Thank you for completing this module.